Hello, this is Leif Solberg, and I'm here to talk to you about using high-tech diagnostic imaging decision support in a large integrated care system. I'm a family physician who has dual roles as Associate Medical Director for Health Partners Medical Group and a researcher. This is what allows me to be able to tell you the story of our experience with a clinical decision support system. Next. What I'm going to do in the next 15 to 20 minutes is to first tell you something about the Health Partners Medical Group and its key regional partner. Next, to tell you about the why anybody would want to use decision support for high-tech imaging, then how it developed here in Health Partners Medical Group and in Minnesota broadly, and then what are its effects as measured by a small study. Health Partners Medical Group is a 800 physician multi-specialty practice with substantial numbers of mid-level practitioners in 35 clinics and 4 hospitals in the metropolitan counties of Minneapolis and St. Paul. We have about 500,000 active patients, and their demographic characteristics are similar to that of the Minnesota population overall. The medical group's patients are associated with a variety of health plans, so we are a multi-payer medical group, but we do have an affiliation with a 1 million member health plan that covers approximately 60% of our patients overall. The environment here in Minnesota is largely fee-for-service, and our physicians are paid by productivity to approximately 90% of their income. Our major partner in the case of the decision support system we're talking about today is the Institute for Clinical Systems Improvement, or ICSI. ICSI is the oldest and arguably the most famous regional quality improvement collaborative, beginning in 1993. It is currently sponsored by 5 of the main health plans in the state, and they provide about $4 million a year in backing. Interestingly, though, the board of directors for ICSI is made up largely of representatives of the medical group members, of whom there are some 55, covering nearly 80% of the physicians in the state. ICSI began to develop common evidence-based guidelines, and over time has gradually evolved to building quality improvement initiatives that at first were guideline-centered and later have become more broad. For example, reducing hospital readmissions, improving depression care in primary care settings. So why would our medical group want to use point-of-care decision support for high-tech diagnostic imaging? Well, there's several reasons. First, the rapid rise in use of high-tech imaging in Minnesota, which, as you can see on the associated bar graph, has been increasing by about 10% a year up through the point at which the decision was made to go ahead and introduce it. So we were interested in being sure that we were providing the most effective use of this rapidly increasing and very expensive technology. Secondly, and probably the main spur to the action that occurred in 2007, was to avoid what was then beginning as a series of prior notification or authorization programs by the payers in the state. Third, we were interested in developing a better evidence base for the use of high-tech diagnostic imaging since there is still substantially little literature on this. We were reinforced in this potential by the fact that Massachusetts General Hospital has reported that its use of a similar high-tech imaging clinical decision support system has found widespread physician acceptability. It has succeeded in reducing the use and increasing the concordance with guidelines from the American College of Radiology. One perspective on United States use of imaging comes from this graph, which shows the United States being second highest of developing countries, right after Greece, in its frequency and volume of use. The red bar on these slides represents the average of the developed countries, and it's almost half the frequency of use here in the United States. The left-handed graph represents MRI exams, and the right half represents CT exams, which were the main focus of this initiative. So in early 2006, the state legislature in Minnesota requested that the Department of Human Services introduce a prior authorization program for Medicaid fee-for-service patients for high-tech imaging. And in early 2007, one of the major payers in the state introduced a prior notification program for the same purpose, and others were clearly online to be doing the same thing. So this spurred the development of a multi-stakeholder steering committee to explore alternatives to these onerous approaches to managing the increasing volume of high-tech diagnostic imaging orders. ICSI was a natural convener for this effort, and it brought together all the health plans in the state, representatives of the major medical groups, groups of independent radiologists, the Minnesota Department of Human Services, and we had a representative of the patients. This steering committee undertook 3 projects. The first was to aggregate claims data from the 3 major payers in the state in order to track quarterly utilization data on high-tech imaging orders, so we could detect whether anything that anybody was doing was having an impact on decreasing the rate. The second project, which is what I'm going to be talking about in the balance of this talk, was to sponsor a pilot decision support among 6 large medical groups. And ultimately, the steering committee hoped to develop a long-term collective solution that could be used by all providers in the state. Here at Health Partners Medical Group, we developed then a decision support system for ourselves and 3 other large care systems, which we provided to them for their adoption and use. It was implemented as a point of care built right into the electronic medical record in 2007 to cover all high-tech diagnostic imaging orders made in ambulatory care settings. The criteria were modified from those of the American College of Radiology and covered about 85% of those orders. A criteria system was established for rating each order on a scale of 1 to 9, with 7 to 9 being high utility or high appropriateness or high fit with the criteria, 4 to 6 being intermediate, and 1 to 3 being low. The ordering physician thus obtained a score as each order was placed, but there was no requirement for either approval or any disincentives from ordering anyway, even though a low score might be obtained. The steering committee asked me if I would develop a study which could help to know the impact of this decision support system using our medical group as a pilot example. So I applied for and received a small grant from our Health Partners Institute in order to perform such a study. It was developed in close conjunction with the steering committee and consisted of a chart audit of primary care high-tech imaging orders for 3 selected indicator cases, and that was done 2 months, over a 2-month period, 6 months before the clinical decision support was implemented, and again for 2 months, 6 months after implementation in the electronic medical record. We selected head CTs, head MRIs, and lumbar spine MRIs in adults with 50 cases of each in the pre and the post case for a total of 300 cases. We established criteria and audit system with nurse auditors conducting the initial audits and 2 physician reviewers reviewing all those cases with questions or positive findings. Overall, comparing the volume of those 3 procedures in the pre to the post period, you can see it has a differential effect on different procedures. Or rather, I should say there's a different association, since we can't necessarily demonstrate cause with a pre-post design. Both head CT and lumbar sacrospine MRI had a 30% decrease from pre to post introduction of this decision support system, but head MRI did not change in volume. There was no limitation on orders, and there also was no aggregate report for feedback to either individual ordering physicians or to the leaders of the group built into the system. Sorry. So here are the results of our study of those 299 chart audits. As you can see, the blue squares represent pre-post comparisons that are statistically significant. So the top row indicates whether a particular order fit with the criteria used in the decision support system, and both head MRI and lumbosacral spine MRIs increased in fit with the criteria, with a comparable decrease in the lack of fit. There was no significant effect on CT head appropriateness ratings, however. The results of the order, as indicated by review of the radiology notes, were as follows. For CT head and MRI head, approximately 50% of the studies were normal, but as you might guess, a much lower percentage for MRI of the lumbar sacral spine, and this ratio did not change statistically in any of those 3 cases. nor was there a change in the proportion of results that were reported as showing incidental findings. And the only change in the proportion of positive results was for MRI of the head, where the percent positive rose from 6% to 28%, as well as a doubling of relationships to the indication for the study. There was also no statistically significant change in the recommendation for additional studies. The physicians also reviewed each of these cases for impact on patients, and as you can see, there are no statistically significant impacts of the clinical decision support system for any of the three conditions, either in terms of their apparent effect on patient health, on the process of care, or more ambiguous situations. Combining all three procedures, overall, there were 10% more cases that had a positive appropriateness rating after implementation of the clinical decision support system, 10% more cases with borderline appropriateness. Of those with positive appropriateness also had the highest rating among the rating alternatives. The limitations of this study are probably obvious to you, including the fact that we have a relatively small sample size, limiting the power to detect differences. This is a report from only a single medical group, and the findings are based on subjective assessments by two physicians. In conclusion, these data do seem to support the feasibility of using chart audits to assess the relationship between appropriateness criteria and high-tech imaging orders. But the introduction of clinical decision support was not associated with any apparent impact on either the frequency of positive findings or patient impacts downstream, although there was a decreased volume and increased proportion of orders that were rated more appropriate. Overall, this graph is the aggregate data for all health plan claims data, and you can see that the steady upward progression up until 2007 appears to have leveled off, which is represented as an average by the yellow bar, in contrast to the red bar, which is a projection of the rate achieved to that point. So the place at which the line flattens out is associated with the introduction of both the prior authorization, prior notification programs by various payers and by the introduction of the decision support system. So we believe that both of these factors were associated and contributed to the leveling off in order frequency. Finally, the steering committee for the ICSI high-tech diagnostic imaging group selected a particular vendor as a common vendor for EMR and web-based alternatives for such a clinical decision support system for all high-tech diagnostic imaging orders and the results. And we worked out a plan that would have the health plans paying the costs of this common system for the state. However, early in 2012, after we had over 100 groups enrolled in this new system, that vendor announced that it no longer fit its business model and that it would terminate the use of this product in early 2014. It was clear that all the stakeholders in the state still preferred a point-of-service system that was accessible at the care site in comparison to any kind of radiology benefit management systems or prior notification systems. So we are continuing to work with the American College of Radiology, which plans to provide and update its criteria through a vendor. In the meantime, our medical group continues to use the system of that vendor until we have a report. So we don't know for sure where this is going to end, but I'd be glad to entertain any questions that you may have about it.